Good morning, everyone. So I'll discuss about the systemic therapies that we have for clear cell and mucinous. So for clear cell in early stage 1A and 1C disease, the prognosis is really good compared to the serous ones. And the slide is not moving. And the 5-year disease-free survival rates were around 84 to 100% and 86 to 89% in 1A and 1C. Now, if you compare the mucinous and the clear cell, probably the clear cell does better compared to the mucinous, and this is grade to grade 1, grade 2 and grade 3. So, for the clear cell, the grades really does not make a much of a difference, but for the mucinous, the grade 3 ones are really the ones which does quite bad. Coming to adjuvant, this is the multicentric. This is the publication which had 101 patients of clear cell versus 235 of high grade serous was compared. All of them underwent surgery followed by adjuvant. This is an old study. The results were that it was evident that clear cell was more likely to be early stage. The recurrence rate was around 37%, and the survival rates of patients with clear cell were lower than those for stage 1 to 3. So this study was pointing at a lower survival, but there are other studies like this is from the Hellenic group. This is again an older study. 105 patients, response rates was different. It was 45% versus 81% for serous. However, there was no difference in the PFS after 61 months of follow. The NCCN says that for 1A, 1B and 1C1, platinum-based therapy or observation is an option. For 1C2 and C3, it recommends platinum-based chemotherapy. Now, 3 cycles versus 6 cycles, we do not know, because the initial action trials, they showed that 6 cycles actually benefits those who have a serous morphology. So, whether giving 3 cycles is sufficient for early disease, that answer we really do not know. For stage 2 and stage 4, definitely systemic therapy is indicated for clear cell. And this is the ESMO-ESGO conjoint guidelines, which states that 1C2 and above, definitely chemo is indicated, but for 1A and up to 1C1, adjuvant chemotherapy is optional. Now, this was the trial which has been discussed previously also, which tried to look at a different combination of irinotecan plus cisplatin versus Paclitaxel plus carbo. So, around 670 patients were included, stage 1 to stage 4, a large broader stage was included in this trial. This was the irinotecan schedule, where it's day 1, 8, 15 at 60 milligram per meter square plus cisplatin 60 mg per meter square every 4 weekly versus the standard Paclitaxel carbo. The primary endpoint was progression-free survival, and the secondary endpoints were overall survival. It had a good median follow-up of 44 months. So, if you look at the outcomes, there was not much difference, both in the PFS and the OS, both the arms had almost similar results. Now, if you look at the stage distribution of this trial, so almost 60 to 60, almost 70% of the patients, 60%, 65% of the patients actually had a very early stage disease. And the new combination was not better than the standard combination. So, even in an early stage disease, it doesn't make a difference whether you give Paclitaxel carbo or whether you give irinotecan cisplatin. Definitely the side effect profile differs, and since we are more comfortable with using taxane carboplatin, I think most of the centers are following that. Now, this was what I was talking of. Is chemo really beneficial? Because there are multiple retrospective analysis as well as the subset analysis from the combined trials of the ACTION and the ICON initial trials, which shows that probably even up to 1C, a clear cell might not see a benefit of using chemotherapy after surgery. This was a meta-analysis, systemic review and meta-analysis for observation versus adjuvant in stage 1, and you can see that adjuvant chemobtherapy, they concluded that the adjuvant chemotherapy does not improve the outcomes in 1A and 1B. However, there is suggestion that it might do in 1C. Now, coming to the advanced recurrent disease, there are multiple pathways which are aberrated in clear cell, most commonly the ARID1A mutations. Also, we have the PIK3 MAP kinase, then the mismatch repair deficient pathway, and the mesenchymal pathways. Now, coming to the specific agents, bevacizumab, there was this ICON-7 study which is famous for bevacizumab. Well, this study included patients with stage 1 and stage 2A clear cell, and no benefit of bevacizumab was reported in the clear cell subpopulation. Also, there was a retrospective study. However, since it's retrospective, it has its problems, but it has shown some benefit which was statistically significant, numerically higher, but we do not have a proper phase 1, prospective phase 3 trial of clear cell alone. Coming to temsirolimus, mTOR is one of the pathways which have been evaluated here, and when compared to historical controls, this regimen again did not have any statistically significant improvement. Also, people looked at the anti-PD-1 nivolumab, which is irrespective of the PDL expression in these patients, and 2 patients had this were clear cell from in this study, and one of them fortunately achieved a complete response, but we do not have much data of nivolumab in clear cell. Avelumab, again another anti-PD-L1 was tested. There were 2 patients and 2 of them achieved a partial response. So, it is just still it is at the level of case reports and case CDs that shows modest responses with immunotherapies and not that exciting. Newer pathways are being explored. These are the common areas which investigators are looking at, especially the demethylation, the EZH2 pathways, and the HDAC inhibition pathways. These are coming up because a lot of clear cell carcinomas do have problems in these pathways. Coming to mucinous, it is again a rare tumor, 5-year OS around 90%. However, it comes down as we go up the stage. And this was shown by Dr. Sekhon that KRAS mutation is probably a very early event, and the HER2 and the TP53 picks up as we go from the borderline to the expansile in the infiltrative type. And this was the flowchart that is followed for most mucinous. I'd stick on to the adjuvant chemotherapy part. So, you see that for 1A and 1B expansile type, you can actually observe. For 1C, the world is split between observation and adjuvant. However, 2 and above for expansile, you definitely need to give adjuvant chemo. For the infiltrative pattern, again, there is no clear subset which states that you can absolutely observe. It's divided, observe versus adjuvant, because they have a slightly poorer prognosis compared to the ones in the expansile group. So, overall survival is higher for the majority of the patients presenting in stage 1. However, the trend is reversed for stage 3 and stage 4. Again, the NCCN states that for 1A, 1B you observe, for 1C observe versus systemic chemo, and 2 and above definitely systemic chemo. This is more or less consistent with the ESMO guidelines also, where it has a similar recommendation. Now, what about the GI type regimen? So, there was one study, randomized trial of 4 arms, which was trying to look at the difference between paclicarbo versus a Capox, as well as a Bev based regimen versus a non-Bev based regimen. However, it was stopped due to poor accrual. The median follow-up was 23 months. Only 50 patients could have been accrued. There was no difference in the PFS and OS. We although cannot rely on the statistics of this trial because it did not reach its target accrual. Molecular alterations, these are the ones which are seen in colon cancer, also seen in mucinous ovarian cancer, RAS being one of the commonest ones, and RAS and HER2 amplifications tend to be mutually exclusive. Now, these are the pathways that we actually can target in the future, specifically the HER2 amplification and the HER2 mutation, which have definite therapies which are proven in other cancers like colon cancer. We also have the options of doing an MSI and a PIK3CA, and we can extrapolate the data that we have for these drugs to those who have relapsed after multiple lines. This is a very preliminary study. You can see the control mouse and the cetuximab given mouse. This was the tumor, and which has reduced, which is completely gone in this. So there are some preclinical evidence of using cetuximab in mucinous ovarian cancer, but they are yet to come up in clinical trials. So this was again a subset group of patients who was given who were enrolled in the basket trial, and 23 out of 55 patients had a KRAS mutation of ovarian cancer epithelial, and CA125 responses was observed in all patients who have an evaluable RAS mutant patient treated with a MEK inhibitor combination. So that is to some extent promising. And also people are looking at P53 pathways and they are yet to see the light of the clinical trials. So to summarize, clear cell adjuvant is same as serous. There is no proven role of substituting irinotecan cisplatin to paclitaxel carboplatin. There are evolving molecular therapies. For mucinous, although the data is data did not become successful in a prospective study, but there are ample retrospective evidence that probably 5-FU based regimen works better compared to the standard taxane carboplatin. Thank you.